Welcome. So it is my honor to introduce Dr. Jennifer Stevens-Lapsley. She's been a member of APTA since 1997 and a recipient of the POD scholarships from the Foundation for Physical Therapy Research. She received her bachelor's degree in biology from the University of Virginia and her master's in PT, as well as her PhD in biomechanics from the University of Delaware. And she completed a postdoctoral fellowship at the University of Florida. Jennifer became a Catherine Worthingham Fellow of APTA in 2020 and has received numerous honors, including APTA Geriatrics Research Award, Excellence in the Stephen Rose Award for Excellence in Orthopedic Research, APTA's Dorothy Briggs Memorial Scientific Inquiry, as well as the Jack Walker Award for Clinical Research Publication, and numerous others. It was going to take the whole time. So Dr. Stevens-Lapsley is currently a professor in the Rehabilitation Sciences PhD program, director at the University of Colorado Anschutz, as a health scientist at the Geriatric Research Education and Clinical Center at the VA Eastern Colorado Healthcare System, and the director of the Restore team. And if you aren't familiar with the Restore program, I think we're going to learn about it today. But it's looking at enhancing mobility and movement and quality of life in older adults through innovative rehabilitation research. She's driven by a passion for evidence to raise the bar in clinical practice with a focus on high-intensity rehabilitation for older adults, including those in nursing homes. Her research is clinically based and has had funding sources including federal, state, and foundation sources totaling at least over 30 million, which was the last that I saw a couple years ago. She's also responsible for helping create some of the next generation of geriatric physical therapy researchers, including some names you may recognize like Jason Falvey, Allison Gustafson, and Emma Beisheim-Ryan, just to name a few. So please welcome Dr. Jennifer Stevens-Lapsley as she challenges us with her CBL lecture this year.
Thank you for that very kind introduction. I want to start by thanking the Academy of Geriatrics for this tremendous honor to give the Carole Lewis Lecture. It's a privilege to contribute to an event named for Carole, whose commitment to advancing geriatric rehabilitation has really shaped the trajectory of our field. And I also want to thank Jason Falvey, Kate Mangione, and Allison Gustafson for the nomination for this opportunity, each of whom represent the very best in our profession. My disclosures. I want to start today with a story of a patient that you already know. You may not know him by name, but you do know his story. He's 88 years old. He lives at home with his wife of more than 50 years. He's independent, cognitively intact. But then he fell. He was hospitalized for a pelvic fracture and a humerus fracture. He caught COVID in the hospital. And eventually, like many older adults, was transferred to a skilled nursing facility. He had one goal. He wanted to go home. I want you to watch him do the sit to stand as if he's a patient in your clinic. I want you to watch how he stands and sits and think about, what does this activity tell you about his strength, his balance, his potential? What exercises would you give him? What level of independence would you allow him? Let me tell you a little bit more. So he was in the skilled nursing facility for almost 2 months at this point. His rehab services had been tapered down quite a bit, and his progress had essentially plateaued. He was given 3 exercises: a seated short arc quad, a seated plantar flexion, and a seated dorsiflexion exercise, all without resistance. He was told he could not stand out of this chair on his own without someone from the facility there. And of course, the facility was short-staffed. So he could not do the very exercise that would help him get stronger and go home. I should tell you that this individual is my uncle. And his name is Dave. And watching him sit in that chair was very uncomfortable as a clinician, as a researcher, and as a family member. But this isn't a story about a bad therapist or a bad rehab team. It's a story about how the environments in which we work shape the care that we're able to provide. Ultimately, what does a family member do in a situation like this? Well, I stepped in. I told my uncle, you better park that chair against the wall, put the brakes on. Remember, he's cognitively intact, and do that sit to stand throughout the day. It's safe. Falls into the wall, falls back in the chair, as safe as it's going to get, right? I gave him some tricep dips in the chair as well, and he got stronger. His trajectory changed, and he went home. But I should not have had to step in. A family member should not have to override a system that is not aligned with the evidence. Ultimately, Uncle Dave did not go home because of what I said. He went home because he had the practice, the intensity that allowed him to be challenged. He went home because he gained enough physical function and strength. And the uncomfortable truth is that all too often, whether or not this happens has less to do with the evidence and more to do with the culture and the leadership in our clinical environments. In fact, as a profession, we have already decided, we've already said that this type of care is not acceptable. So why does it continue? And that is the problem that I want us to wrestle with today. How many of you heard of choosing wisely? So choosing wisely represents moments where our professions came together and said, we know better than this. In nursing, it's don't let older adults lay in bed or only get out of a chair during their hospital stay, or get up to a chair during their hospital stay. And for PT, it's don't prescribe underdose strength training programs for older adults. And yet, if you think back to my Uncle Dave, he was sitting in a chair doing low dose exercises with intact cognition and a clear goal of going home. So the problem wasn't a lack of guidance. It wasn't a lack of evidence. The problem was that what we say we value and what our systems actually value and support are often not the same thing. So the question isn't usually whether we know what to do. The question is why it's still so hard to do it. And that's where leadership, culture, and implementation come in. And at this point, we're left with a tension we all recognize. We care deeply for our patients. We know what good care looks like. And yet too often, people like my Uncle Dave still end up stuck in chairs. The gap is not about motivation, and it's not about knowledge, and it's rarely about an individual clinician. Today, I want to do a few things. First, I want to name the problem clearly, and then I want to show you the opportunity that exists when we stop treating these issues as isolated clinical problems and start seeing them as a system and culture problem that we can actually influence using some real life examples. And finally, I want to give you some practical ways to think about leadership and culture that you can use in your own settings, regardless of your role. Because if we can get this right, people like Uncle Dave don't need a family member to step in to change their trajectory. The system should do it for them. So we'll start with the problem. Let's zoom out just a bit. Imagine 100 evidence-based practices were developed today. How many do you think would make it into clinical care? Turns out only 14. Do you think that's a reasonable amount? Now, how long do you think it takes to get those 14 evidence-based practices into clinical care? 17 years, all right. How many people think that's a reasonable amount? So think of all the families and the patients that were impacted by this delay, that missed out and that could have benefited. Even when the evidence is implemented, adherence often drops by half after a year. Now, because we're at this conference, I'm pretty sure I know something about most of you. You care deeply for your patients, you're motivated to learn, and you're committed to advancing care. And yet, when we step back and look across practice more broadly, the picture is a bit uncomfortable. A systematic review involving musculoskeletal practice patterns found that only 54% of clinicians report using recommended treatments. 43% report using non-recommended practices. So let's make this real. Dave was cognitively intact. He wanted to go home, and he needed progressive, appropriately dosed exercise. Based on those numbers, when Dave entered that skilled nursing facility, there was essentially a coin flip chance that he would receive care aligned with what we recommend, and a 43% chance that he was going to receive care we already agree is not recommended. Just sit with that for a minute. For someone who's vulnerable, someone who is dependent on the system, and whose independence is on the line, is that acceptable? What if I told you we could decrease that lag time for getting high-quality evidence-based practices into care from 17 years to as little as 5? What if I told you we could increase the chance that Uncle Dave will receive treatment aligned with evidence-based practice to 80% rather than 14%? More recent evidence suggests that we can decrease this lag time for getting high-quality evidence into practice from 17 to as little as 5 years. And how this is possible will be the focus of what's to come. So that's the problem. The challenge is translating evidence-based practice into clinical care. So what's the opportunity? Think about a time you tried to implement something in your clinical system, your clinic, your healthcare system. Did everything go perfectly? Was it smooth sailing? No bumps in the road? Or did it ever feel like you were trying to forge this river? It turns out there are so many factors that impact our ability to get evidence over the bridge and into practice. Raise your hand if you have heard of implementation science. All right, fantastic. To understand how this is possible to shorten that timeline from 17 to 5 years, and before we get to the meat of the presentation, I am going to highlight just a little bit about implementation science for anyone who is not as familiar with implementation science, because it's a relatively new field that acknowledges the complexity of our healthcare environments and provides a structured way to address that complexity. It essentially helps bridge the gap between what we know and what we do. And I could focus an entire presentation on implementation science, but think of it as trying to achieve similar goals to quality improvement initiatives. So even though we have the best evidence, in this case, that we need to increase mobility and we need to use higher intensity progressive exercise, without the right implementation environment, it just won't succeed. The best evidence just won't translate into practice. So when we think about developing evidence-based practice, many of you are familiar with published efficacy studies. These are tightly controlled studies followed by effectiveness studies, which are less tightly controlled. And these implementation studies extend that continuum. We're focused on that last gap of getting across the bridge and translating evidence into practice faster. So when we have a clear intervention and a well-designed implementation plan, it is tempting to believe that success should naturally follow, that we can simply march across that bridge and arrive on the other side. But in practice, it's rarely that simple. Implementation depends on people. And people don't change just because the evidence is strong. They change when the environment supports them. So winning genuine buy-in is often the hardest part, not because clinicians resist the evidence, but because the systems in which they work make change difficult to sustain. So through the examples that I'm going to provide throughout this presentation that involve implementation practices are not specific to any individual facility or clinical organization or setting. Rather, they reflect the common dynamics that emerged across multiple sites and organizations and settings. Our work has been possible because of the partnerships with many highly committed healthcare organizations, and I'm grateful for the opportunity to work alongside them. I also want to acknowledge my Restore team as they are passionate about translating evidence into practice across numerous settings and populations. The examples I share today come from the foundation this multidisciplinary team has built over many years. I'm grateful to lead this team and proud of what we've built together at the University of Colorado. So let's explore some real-life examples. So our patients and their families often choose rehabilitation clinics based on what they can see from the outside at first glance. Many facilities appear similar in their physical structure and amenities, but on the inside, they can be profoundly different in the quality of the care they provide. These internal differences shape everything from patient engagement to functional outcomes. So we're going to consider these two facilities that look nearly identical: Mediocre Meadows and Get Up and Go Gardens. I hope you're already envisioning some of the things that make these facilities different. Throughout the rest of this presentation, we're going to contrast these two facilities. So in my journey across the country, whether it's home health, outpatient, and especially skilled nursing facilities, if I walk into most rehabilitation clinics, it's not uncommon for me to see an individual seated with a 2-pound ankle weight strapped around their ankle doing a knee extension exercise. A lot of times, this individual is 6 foot, 250 pounds. Now, you don't have to go back to your days of biomechanics to really think through, is that 2-pound weight really preparing this individual to stand up and out of a chair? But that's usually the answer I get from the therapist that's working with the individual in terms of why they're doing this particular exercise. And I liken it to us prescribing medication, the same amount of blood pressure medication for all our patients, regardless of size, age, or other physiology. And the disconnect rarely results from a clinician's negligence or lack of caring, even in the case of my Uncle Dave. Instead, it reflects a cultural norm and some leadership signals within rehabilitation environments. In settings where productivity dominates, where clinicians receive limited guidance on dosing and progression, and where risk aversion outweighs functional goals, low-intensity practices become normalized. Let me tell you a story about Elaine. I was working with a therapist, and Elaine was doing a sit-to-stand activity, just as you see here, with the armchair pushing off with her arms. She did 10 sit-to-stands, and she didn't look all that fatigued. So I said to the therapist, can we try that without the use of arms? Can we have her cross her arms across her chest? And the therapist turned to me and said, she's 95 years old. I said, I know, let's just try it. Sure enough, she was able to do it. No problem. Arms crossed across her chest. She still didn't look like she was challenged enough. So I said to the therapist, can we put a weight vest on her? And the therapist now really thought I'd lost it, but acquiesced, and we put a weight vest on her, asked her again to cross her arms across her chest, and she was able to continue with that activity. She had 30 pounds of weight in that weight vest, no arms, and able to do that activity to what we describe as failure, to the point at which she couldn't do it with proper form. That was the dose she needed. And where did she start? With the use of the arms and the armchair. Now here's a story out of Mediocre Meadows, a video. What I want you to see here is that she's passively pedaling on the exercise bike, but she's asleep. There is no resistance. She's been pedaling for 13 minutes. At Get Up and Go Gardens, we see that the intensity matches the potential of the patients. Very hard, and people are wearing weight vests. Because the reality is that that groceries, stairs, and grandkids don't get lighter. So we implemented a high-intensity functional resistance program in a variety of facility settings, and most notably skilled nursing facility settings. Our first effort was with colleagues at our state vets home. It was a pre-post design, over 100 individuals, and we taught these therapists to implement this high-intensity program that's called I Stronger, and involves many functional activities. We use progressive functional activities designed to deliver an adequate physiologic dose for walking, balance, and functional activities, like I said. The intervention doesn't take more time once you learn how to do it. It does take a little bit more cognitive thought. You have to think about how to put the pieces together. But most of the time, our therapists tell us once they learn this, they can't unlearn it. And the basic premise behind our I Stronger program is that if you can do more than 8, up the weight or increase the level of difficulty. In this first iteration with over 100 individuals, we had some pretty remarkable findings. We had the team was very cohesive. They had really great leadership, great culture, all the things that allows us to put something like this into real world clinical practice and get results like this. One of the most notable findings was we increased the community discharge rate by 20%. So 20% more people went home. We also saw that we decreased the length of stay. So we sent more people home in less time, and we saw an improvement in walking speed that was both significant and clinically meaningful. We went on to train clinicians in a variety of other settings, including community living centers, which is the VA's equivalent of a skilled nursing facility. And we implemented the program and used an iterative refinement strategy for working with these therapists. So we continued to learn from them and improve how we delivered this intervention. And our therapists would often say after receiving this training that I had no idea how much I was underdosing my patients. They not only tolerated the high intensity training well, but I was now tailoring the intervention to each person's capabilities. Others would say it's been a good way to motivate our patients to do more, improve our expectations, and move them towards the things that they're going to make their life easy once they discharge. And from a patient's perspective, it was not uncommon to hear from patients who had had experiences with prior rehabilitation and could contrast what they were receiving with this new program.
And I'm so motivated, I'm so excited every time I go to therapy that, I just can't get enough of it. I come into my room and I'm doing this at night, guys. Look, right here on my own, in my own room. This is how motivated I am.
And how was the intensity compared to where you were before in terms of therapy experiences? Was there a difference in the types of things you were doing or the intensity with the weights and things like that?
It was a major difference, just the intensity and the different things that I'm doing versus before over there was just real simple. This started out simple and started getting harder, but I could see how it was working, what it was doing for me, and the final results, and my intensity is just, I'm highly motivated all the time.
Did you ever get to wear the weight vest?
I sure as hell did. Thank you to Mr. Ronnie. I looked at it and I kept saying, okay, so, we put the weight vest on, and I do this bit right here, and I do it 5 or 6 times. Okay, hold on. And before you know it, he's adding more weights to it. And then I told him, I said, Ronnie, how much am I putting on? Or what do you have on me? Oh, it's just 40 pounds. But hey guys, you know what? Thank you, Ronnie, wherever you're at. But yes, it was another level, and I could see why. It's at another level.
So we continued this work with a large trial. We partnered with Aegis Therapies. They've been a leader in the skilled nursing facility industry, and their willingness to invest in our team and learning created the conditions to launch this large-scale study. And we looked at sites. We randomized sites to either usual care or I Stronger, and delivered this intervention over 15 months. We did this all around the country. We trained over 100 clinicians. We had numerous focus groups. You'll see quotes from some of those focus groups and interviews in a minute, with almost 4,500 patients. And we've learned a lot. We've learned that high intensity is safe when you monitor vitals and adhere to precautions. Patients have taken more readily in many cases. Now, I'll tell you, Leo's a great example. Not all patients are that motivated, right? But many were surprisingly more motivated to participate than we thought. We've also seen that therapist productivity does not decrease once you learn how to implement the program. And we need to better determine still for whom does this really work best. We're still looking at thousands of patients, and for whom is this best geared? Because there probably are some limitations in terms of who's going to benefit the most. And we're also continuing to learn how we optimize training for our therapists, because it's not as simple as just putting on the weight vest all the time. And while the findings of the study are not yet available, one conclusion is already clear. Regardless of the eventual outcomes, I can state with confidence that older adults should not be falling asleep while exercising. So I suspect everyone in this room wants to do what the evidence tells us. I'm going to give you a chance to stand up. Stand up if you agree with that statement. You want to do what the evidence tells you. Now, I want you to stay standing if you feel one of these pressures impacts your ability to implement evidence-based practice. How about productivity? How about payment pressures? How about documentation? I could add to the list, but you'd be standing for a while, so you can sit back down. Throughout our implementation science work, we began to see firsthand how these pressures are experienced and managed is largely determined by leadership and culture. Expectations set by leaders influence what is prioritized, what feels feasible, and what risks clinicians are willing to take. So we have the evidence, and I suspect you want to follow it. So why does it take 17 years to translate into clinical practice? Let's take a peek back into Mediocre Meadows and Get Up and Go Gardens to better understand what might contribute to the delays in translation. So we're going to look at these two facilities. One's a lower performer, one's a higher performer with respect to evidence-based practice. And we're going to start with some examples of how most people think about this. And then I'll give you a framework to better structure how to think about challenges and opportunities with respect to culture and leadership that each of you can use in your environments. So in Mediocre Meadows, here's an example. A facility that experienced a revolving door of 3 DORs in a year. Or a clinic that was chronically understaffed with open positions for 1 or more years. Sometimes sites relied on telehealth to address staffing shortages, which contributed to siloed communication. Or some sites where nursing didn't talk to rehab at all. They didn't have patients ready for therapy. And then there were competing priorities. Maybe there's a continence management program, shift in policies with COVID, and changes in group and concurrent requirements. At Mediocre Meadows, what does all this lead to? Minimal adoption, early fade out. So let's contrast that with what's happening at Get Up and Go Gardens, our high implementation facility. Here, the director of nursing and the director of rehab collaborate on how to optimize having patients ready for rehab. And through this coordinated effort, they expect all clinicians to be engaged. Even when the DOR was not a PT or an OT, they took the training. Maybe they were a speech therapist. They took the training and engaged in our case-based examples. They learned the principles of I Stronger and supported them. And they also prioritized time for the team to connect and learn. And the outcome of all this is rapid uptake, sustained delivery. Ultimately, these differences did not stem from the intervention itself. It's the same intervention. It stemmed from the implementation, leadership, and culture. Same evidence, same constraints, very different outcomes. So let's talk more specifically about leadership characteristics that shape culture and promote adoption of best practices. This is the same bridge that we saw helping us cross the raging river. Going from evidence to practice, again, looks really straightforward. But remember, it takes 17 years to cross that bridge. What's often missing is leadership and culture. But it's not surprising that it's missing. Most of you have taken many clinical education courses. But how many of us have taken leadership training, have been formally taught to address a conflict with an employee, or how to give feedback to a poor performer? How many of you in management were provided specific leadership coaching? I'm going to give you some leadership targets that are going to help us cross that bridge. Remember, we want 20% more people sleeping in their own beds, 20% more grandparents playing with their grandkids, 20% more people eating meals at their own kitchen tables. And we want Uncle Dave to go home. Since ultimately, the Uncle Dave problem is not a therapy problem. It may be more of a leadership problem that we can solve. We ultimately want to take that 17 years and bring it down to 5 years or less to bridge evidence into practice. Now, I didn't start my career thinking about leadership or culture. I started it by trying to get interventions to work. But after watching the same evidence succeed in some places and quietly disappear in others, a pattern became impossible to ignore. 5 team dynamics kept showing up. When they were present, evidence moved. When they were missing, even great interventions stalled. So there are 5 things that differentiate mediocre meadows and get up and go gardens that we're going to discuss in just a bit more detail. And as I go through these, I want you to think about which ones resonate with you. Which ones could you start to implement immediately? And I want to acknowledge that this framework was developed by Potentia. Everything we do starts with purpose. It's the why behind what we do. Can you think of ways in which, in your clinical worlds, where purpose becomes fragmented? This is what the fragmentation looks like in practice. These are from interviews from hundreds of clinicians. They're representative of a variety of different clinics and environments, like I said before, but it's things like you see in this quote. It's hard to always hit my metrics or performance indicators. And if you're always thinking of the patient first, I feel like those 2 things clash. Most people can relate to that. As clinicians, we want to do right by patients. And sometimes productivity, metrics, and patient care feel like competing priorities. When these priorities collide, purpose feels fragmented. And in the moment, maybe people default to what feels safest or most measurable, even when it underdoses care. For example, a therapist might say, I know my patient needs to practice that sit to stand at a higher intensity with that weight vest, but I don't have time to go get the weight vest. And instead, if I run behind or I document late, that's what's going to get flagged by my supervisor. So I end up not taking the extra time to get the weight vest. What do you think that does, though, to the motivation of that clinician when they're forced to choose the productivity metric as opposed to the highest quality care? Ultimately, it wears the clinician down. And that's why purpose is so important, because the best organizations figure out how to prioritize productivity and high quality patient care. Take a look at the quote from Get Up and Go Gardens. Number 1 goal is to help the patients and get them better. I know what you're thinking. That's a little too idealistic, right? And you're right, because we're missing something. At Get Up and Go Gardens, the tension between productivity and patient care doesn't disappear. Instead of purpose-driven Get Up and Go Gardens, a therapist might say, instead at purpose-driven Get Up and Go Gardens, a therapist might say, what's the most efficient way to move this patient closer to independence? And very often that means fewer exercises, not more, but practiced at the right intensity with clear intent. So for example, it might have taken more time to go get that weight vest, but the therapist might have been able to do fewer repetitions and hit the right dose. Work smarter, not harder. So at Get Up and Go Gardens, productivity is not ignored. but it's framed as something to be achieved while in alignment with purpose, not in competition with it. But common purpose is not enough. We also need clear accountabilities. Be honest, how many of you have thought at least once, I assumed someone else was handling that? And how many times have you been that someone else? Accountabilities typically don't fail because people don't care. They fail because ownership is assumed instead of assigned. At Get Up and Go Gardens, accountabilities for high-intensity rehab are explicit. Before the week starts, the team is clear on roles. The PT is accountable for setting and progressing intensity tied to functional goals. The PTA is accountable for delivering that dose consistently and flagging when progression stalls. Nursing is accountable for supporting mobility outside of therapy sessions. And the rehab director is going to reinforce expectations and remove barriers. Because ownership is clear, progression happens, dosing is discussed openly, and missed opportunities are addressed early. At Mediocre Meadows, well, you can probably guess what's happening there. And here's the bottom line. Most organizations are not very clear on role expectations. In fact, about 46%, that is nearly half, of all performance problems across organizations are tied back to unclear accountabilities. Just think about that. What can you do in your organization, in your setting, with that in mind? When no one is clearly accountable for dose, progression, reinforcement, high intensity is going to stall. This quote shows what happens when accountability gets boiled down to metrics alone. Again, that productivity theme keeps coming up, right? There's no accountability other than what's your productivity number and what's your concurrent number. At Get Up and Go Gardens, this quote shows the opposite. Accountability is clear and explicit because everyone's assigned specific tasks and held accountable. I do the daily schedule. I run the documentation reports. I make sure it all gets done. Not all the same person necessarily, by the way. Raise your hand if you have worked in an organization with perfect communication. I don't see any hands. Communication gets blamed for almost everything, and we could spend an entire lecture on it. Most communication breakdowns don't happen because people don't care. They happen because people care differently. So I'm going to give you an example. Matthew is metrics driven. He cares about patients and efficiency, and when he talks about high intensity rehab, he emphasizes schedules, throughput, and productivity. In contrast, Sarah is relational and supportive. She builds trust, avoids conflict, and when intensity feels uncomfortable, she prioritizes rapport and safety, even if progression slows. Both care deeply. The problem is not motivation, it's communication. Matthew talks about intensity in operational terms, and Sarah hears productivity pressure, not clinical intent. Sarah avoids conversations about dose, and Matthew assumes the message is clear. Without clarity, intensity gets diluted and care drifts back to low demand. At Mediocre Meadows, these mismatches go unaddressed. Assumptions replace shared understanding, and high-intensity rehab quietly erodes. But now contrast that with Get Up and Go Gardens, where communication is intentional. Leaders set clear expectations for appropriate challenge. Matthew frames his intensity around recovery, not throughput. Sarah is supported to have honest conversations about dose and progression. Different styles are valued, but expectations are shared. When we look at our quotes from various interviews, Mediocre Meadows on the left. Notice what's happening here. The speaker has ideas, insight, and expertise, but doesn't feel safe to speak up. We could do better as a team. I've tried to interject here and there. It's not well received because it's perceived that I'm a know-it-all. On the right, we have a very proactive team. We're constantly in communication with everyone. Here, communication flows across roles. Expertise is welcome rather than defended against, and there's ongoing dialogue. How many of us have chased down multiple people to figure out who could make a decision. Yeah. And by the time you find the person, the opportunity for action might have passed, right? So sound decision-making is the next one on our list here. And it's not about making perfect decisions. It's about making it clear who decides what. Decision ambiguity ultimately costs time, confidence, and momentum. And in rehab, lost momentum often means lost recovery. So at Mediocre Meadows, if no one owns decisions about patient care, how is it possible that we can make the right decision? So here's an example. A PT believes a patient is a good candidate for iStronger, but another team member is not sure. No one's sure how that disagreement should get resolved, so the team avoids the decision altogether and defaults to the lowest risk option at the moment, which is lower intensity, less challenge, no clear progression. As a result, the patient misses an opportunity to meet their full rehab potential. This is what decision ambiguity actually sounds like in practice. I've seen it. If it's his idea, it's cool. If it's not his idea, we're not going to do it. This quote captures a culture where decisions are driven by hierarchy and personality rather than role clarity. People learn quickly that it is safer to wait, defer, or stay quiet unless the right person is speaking. Now contrast that with this quote. Here, decision authority is intentionally placed on the clinicians closest to the work. My PT and OT create the schedule. Some DORs do the scheduling themselves, but the PTs and OTs are better suited to distribute the patients because they know the patients. Finally, in high-functioning teams, every team member intentionally looks for what each person does well and then builds around it. In weaker teams, people are assigned tasks based solely on vacancies or schedules or convenience. The difference shows up quickly in engagement, retention, and implementation. As a leader, how do you know your team is high functioning? Well, it might be when one of your team members says, hey, boss, I think someone else could do that job, that piece of that job. They're willing to speak up. They're willing to acknowledge that other people have different strengths that maybe you don't have. This quote on the left from Mediocre Meadows reflects what's happening when experience and contribution are invisible. My 33 years in role as champion, I didn't even get consideration over a new grad that they put into the DOR position. What you hear is not just disappointment about a role, it's a lack of understanding. No explanation, no acknowledgement of strengths. Regardless of whether the promotion decision was justified, which it might have been, the person walks away feeling unseen. In contrast, highlighting strengths, in this individual, I feel like you'd be good for X, Y, and Z reasons. And not only did it give me an opportunity to highlight strengths to them, but it also just helped them feel like their work is appreciated. Here, feedback is explicit and strengths are named. And the leader uses everyday moments to help their clinicians understand what they contribute and why they matter. So why is it worth paying attention to all this? Because we don't want this to happen. We can drop high-intensity functional resistance training into clinics and still have people falling asleep on their exercise bike. Because poor implementation culture and leadership environment are driving the lack of change. We know that this is not evidence-based and our patients deserve better. No matter how strong the evidence is, it won't translate into practice if leadership and culture are not aligned. So people don't change because the data are convincing. They change when the environment makes the right behavior possible. Leadership is that bridge between evidence and action, and it turns knowledge into motivation and culture into sustained behavior. And I want to go back to where we started. At the beginning of this talk, I said it takes 17 years to translate evidence into practice. What I hope is clear is that 17 years is not a law of nature. It's a reflection of the environments we build. When leadership and culture are misaligned, change slows. But when they're aligned, that timeline can shrink dramatically. Ultimately, with the right leadership and culture, we can go from 14% to 80%. And we can do it in less than 17 years. So ultimately, now you know the 5-team dynamics. What do these mean to you? What can you do as a clinician to implement some of these principles in your own settings? And what I'm about to say doesn't require a new title or more authority. It requires intentional behavior, exactly where you are. So for the frontline clinicians in the audience, your influence starts with a common purpose. You decide every day whether care feels routine or meaningful. A concrete action is to consistently tie what you're doing to patient independence and recovery, especially when time is tight. When your purpose stays visible, evidence-based care stops feeling optional. Consider identifying one patient this week and deliberately dosing one activity to true physiologic challenge. As a frontline clinician, you also shape effective communication. So how you raise concerns, offer suggestions, or respond to feedback determines whether your team learns or retreats. One practical step might be to ask a question that invites collaboration, rather than defaulting to silence or frustration. For example, instead of thinking, "This will never work here," ask, "What would need to be true for us to try this on one patient safely?" That question signals openness, invites problem solving, and keeps learning alive rather than shutting it down. As a frontline clinician, you also bring many strengths to your team, whether or not anyone has ever named them. Some of you are great at building trust with patients. Some of you are precise, efficient, and keep things moving. Some of you ask the questions others avoid. And some of you quietly model high standards every single day. Those strengths matter. Managers and operational leaders make ownership explicit for common clinical decisions. Who progresses intensity? Who determines readiness for discharge? Who adjusts schedules when care needs change? And who has the authority to pause low-value tasks in favor of what matters most? Sound decision-making might mean pushing appropriate decisions to the front lines and clarifying ownership for maybe a recurring clinical decision next week. Think of something actionable that you could do next week. How about your students in the audience here? If you're a student or a trainee, you have more influence than you think. Your role is to recognize and develop your strengths and to practice effective communication early. Ask where your strengths are most useful. Seek feedback. Speak up when something does not make sense. A concrete action might be, when interviewing for a clinical job, ask, "How does this team support growth or learning?" Or start by asking one question about growth or feedback in your next clinical interaction. Choose learning environments that value growth, feedback, and teamwork, since the habits that you build now will follow you for decades. And last but not least, to the organizers of this great event, and for our professional organization more broadly, this is what we can do. We've excelled at teaching techniques, protocols, evidence-based interventions. We've invested far less in teaching how to lead people, how to shape culture, and how to guide change. If evidence lives or dies in teams, then leadership and culture are not optional. They're the core clinical infrastructure. So intentionally, we need to elevate leadership, communication, decision-making, and team dynamics alongside the traditional clinical content. We need to highlight not just what works, but how it works. We need to teach how to lead teams, how to manage conflict, how to build psychologically safe environments, and recognize excellence in building strong teams, not just strong resumes. I want to be really clear about what I'm not asking you to do. I am not asking you to walk back to your clinic next week, decide you have a bad culture, and quit your job. That helps no one. What I am asking is for each of us, based on our roles, take responsibility for one small but intentional action that strengthens culture and gives evidence a chance to stick. Progress doesn't require new programs or permissions. It begins when someone changes one expectation, one conversation, or one response to uncertainty. Fortunately, the APTA already offers some resources through the Academy of Leadership and Innovation. Their website has special interest groups, online learning, webinars, certificate programs, including their LAMP Leadership Institute, which provides training to therapists as healthcare leaders, and their LAMP School of Management, which provides training on best practice strategies for outwardly managing others. There's also the Barney Poole Leadership Academy that's designed to develop and advance leadership skills for physical therapists and physical therapy assistants and students. Maybe you start a new leadership initiative within your organization. AGES had clinical catalysts that were designed to help facilitate putting evidence into practice. Maybe you consider reading a leadership book this next year or listening to a leadership podcast once a month. I want to leave you with this. Evidence doesn't fail because it's weak. It fails because the environments we work in don't always support it. And those environments are shaped by people. Across every example I shared today, from mediocre meadows to Get Up and Go Gardens, the pattern is the same. When teams share purpose, have clear roles, communicate directly, make sound decisions, and use their strengths, evidence has a chance to stick. When those dynamics are missing, even the best evidence fails. So here's my overall charge. Don't wait for a new title, a new job. Whoops, something went wrong there. Hold on. Here's my overall charge. Don't wait for a new job, a new title, or a new strategic plan. Start where you are. This doesn't require sweeping reform. Choose one dynamic. Choose one behavior. Act next week. Because leadership is not about authority. It's about behavior. And culture is not something we inherit. It's something we create every day. If we want evidence-based rehabilitation to succeed, we have to stop treating leadership and culture as background conditions and start treating them as essential clinical infrastructure. That is how we move from mediocre meadows to Get Up and Go Gardens. And that's how we translate evidence into practice in less than 17 years. And when we get this right, it shows up in real lives. It's deeply personal. It's more people having coffee at the kitchen table with their partners. It's more people carrying their own groceries. It's more people living instead of recovering. It's more Uncle Daves going home. And that is how we make sure that the next patient encounter, whether it's with someone you love or someone you've never met, is one that we're proud of. Thank you.
So thank you very much. I think that was really exciting. And we all know that leadership is important. I sat here as president thinking, like, where are all the things we can apply this? We have a new mentorship program launching. If you're not already getting the mentorship or want to give mentorship, consider applying. We're looking for both mentors and mentees. APTA also has leadership development materials. We used to have a leadership development committee in APTA. We don't anymore. That might be another thing for us to push for. And the high intensity interval training task force has presented to the board just this week when we had our board meeting, a position statement that we'll be putting onto the website soon. but it's an endorsement of why we should be doing high intensity interval training for older adults. So thank you to that task force. And I know Jennifer's going to take some questions. So if you have some questions or comments, please feel free to come up to the mic. But I just want to thank her for officially on behalf. We're sending her award to her at home. So she doesn't have to carry it. But thank you so much. And just before people leave, we'll announce for the 2027 CSM will be in Philadelphia. And it's my honor to recognize Greg Hartley as the Carole B. Lewis Lecturer next year.
Happy to take some questions or comments.
Dr. Stevens-Lapsley, I just commend you on an exceptional presentation. I'd like you to also extend our thanks to Uncle Dave, if you would, please. So that was a great placement there, and you really brought this home. Here's my question. When I look at your figures there and I see the dynamics of what happens in leaderships and failings as well as successes, I see a lot of analogies between implementation science and behavioral economics.
Mm-hmm.
And I see opportunities, although there is less of an analogy in the communication because behavioral economics is really about a person making change. And we see things like gamification, we see friction, we see nudge, we see choice burden, paradox of choice, and all of those things you actually represented right up here. So I'm wondering if there are some potential solutions within the science of behavioral economics that you see that you would extend to us as an audience that you see might also offer solutions on more of an implementation science basis at a systems level. Thank you.
Absolutely. That's a great comment. I think it's something that we've started to use some behavioral economics with our patients to encourage good behaviors, right? But I think we have not extended that into as much into kind of our clinical worlds. And it's a great observation. You know, the 5 things that I pointed out are not the end all be all. There's many leadership kind of principles and strategies and ways that we can go about improving our leadership and culture. I love that idea. And I think that's something that we were talking with someone at the University of Pennsylvania that does a lot of work with behavioral economics and thinking about exactly how can we change how can we use those nudges and those principles to facilitate clinical care changes. So it's a great suggestion. Any other questions? Okay, fantastic. Well, thank you all for your time today. Really appreciate it.